Welcome to the session on hemolytic anemias, where our focus is going to be on immune mechanisms and testing. Our objectives are going to be to have an approach to the ascertainment of hemolysis and to conjecture on the compartment that it's occurring in, to have an approach to identifying immune-mediated hemolysis, and to classify the types of immune hemolytic anemia and to state how they're established by clinical laboratory criteria, appreciating technical challenges and how to overcome them. And along the way, we'll pick up some basic science, mentioning players like CD163, Fc gamma receptor 2b, and CD47. The challenge of hemolytic anemia is that it isn't often the cause of anemia itself, i.e., at less than 5% of those cases. And yet, there are over 200 ways to hemolyze. The most important simplification scheme is to classify into the binary of either intra or extravascular compartments of occurrence. This usually aligns with non-immune versus immune. The non-immune classic is MAHA, while the immune modes have a more interesting taxonomy. You can have autoimmune self-destruction or alloimmune, meaning a host versus graft or graft versus host polarity. A person can destroy an incompatible unit, or a unit may convey to them a hemolysin that causes host erythrodestruction. And finally, there may be drug-induced immune hemolysis. The autoimmune hemolytic anemias are classified into warm versus cold, and that speaks to the thermal range of activity and therefore the typical isotype of involvement, while alloimmune is often subclassified as a passive, finite, preformed hemolysin versus an active, ongoing, elaborated hemolytic process, particularly in a situation of chimerism, two immune systems present. So passenger lymphocyte syndromes, for example, falling under the umbrella of active alloimmune hemolytic anemia. At the end of the day, red cell clearance, increased red cell turnover, shortened red cell survival is globulocidal. Red cell hemolysis is an erythrodestruction phenomenon, and it begs the question of what is the lesion, what is the force causing this clearance, and where is it happening? So to speak to step one, to establish whether or not you have hemolysis, you may begin with the clue that there is a pace of red cell loss that's faster than underproduction alone, but bleeding is nowhere to be found to account for that. There may be peripheral blood changes with polychromasia or measured reticulocytosis, and the spun sample may show reddening of the plasma, that is, plasma hemoglobinemia. It may be grossly visible by yourself in the lab or by an ally who you call to ask how that centrifuge specimen looks. And it may be measurable too. More accessible biomarkers, though, in our EMR would be indirect hyperbilirubinemia, lactate dehydrogenase elevations, disproportionate shifts in the AST relative to the ALT, which may be normal, and a relatively decreased with respect to baseline haptoglobin, or the completed depletion or quench out thereof. The combination of a high LD with a low haptoglobin is 90% sensitive to hemolysis. And if red cells are breaking down in the bloodstream, well, then their end products are going to be cleared through the kidney. And you may see proof of that in hemosiderunuria. And you may see pigment nephropathy or actual renal damage from the pigment nephrotoxin that is plasma-free hemoglobin. Be aware, though, that there are mimics that can look just like hemolysis. This giant retroperitoneal hematoma, as it resorbs, can contrive all of these parameters. And so too, Might the person with cirrhotic liver disease experiencing an upper GI or variceal bleed? Coombs testing might be another way to help prove that hemolysis is happening, but by itself is not necessarily evidence that hemolytic anemia is present. Now, how much hemolysis of any kind can your haptoglobin actually hide or quench out before that excess spills over and looks like intravascular hemolysis, even if it's occurring extravascularly? So at what point do you have this escape velocity in free plasma hemoglobin? Well, the answer depends on how much haptoglobin you have at baseline and how much you replace with when this is getting used up. The ratio of haptoglobin coupling to free hemoglobin is 1:1. And so a person with a 5-liter blood volume affords between 1.5 and 10 grams of free hemoglobin mop-up power with that baseline normal haptoglobin level, so long as it's not being continuously replaced. So again, you have ongoing mop-up power so long as you're continuing to synthesize haptoglobin. So if we speak to equivalencies in red cell unit terms, a bag of red cells contains 180 grams of erythrocytes or 40 to 50 grams of hemoglobin. And this amount of haptoglobin has the capacity to scavenge between 3 to 25% of that broken red cell bag. The hemoglobin haptoglobin complex doesn't just achieve detox in the sense of shuttling that toxic free hemoglobin away, but that dimer, that couplet, traffics ultimately to CD163 on monocytes and macrophages expressed in the spleen. And when this complex lands there, you have the release of anti-inflammatory IL-10, which is sort of like a speed bumper brakes to what would otherwise be a runaway positive feedback or accelerating cycle of hemolysis. So this speaks to the value of a retained spleen in being able to secrete a dampener, so to speak. There are dangers of free hemoglobin, and this is often summarized in the INNOVA hypothesis, which stands for impaired nitric oxide bioavailability. Nitric oxide is also known as endothelium-derived relaxing factor. And unfortunately and uncannily, plasma-free hemoglobin, so hemoglobin outside of the confines of the red cell, is able to bind quite avidly to nitric oxide, which means that this is stolen from the endothelial surface, and precapillary arterioles everywhere may go into vasoconstriction and therefore exhibit impaired downstream tissue perfusion as a result. Stealing nitric oxide is also very platelet activating, and that may be part of the prothrombotic harms of hemolysis. Plasma-free hemoglobin is toxic, and so too is the iron and the oxygen without all of those redox controls. So you have unrestrained inflammatory cytokines and oxidative damage, Fenton chemistry, and so on happening with the release of this highly powered molecule. Now to get to question 2, where is the lesion? Is it intra or extravascular? Because the eye of the needle is making direct contact with the compartment of the intravascular space involved in intravascular hemolysis, the parameters are going to be much more abnormal here, more overt. Extravascular hemolysis, which is happening cellularly within the confines of phagocytes within the spleen, take a lot more red cell clearance to evidence that damage and biochemical spillover. So you can have a lot more hemolysis extravascularly before you are convinced by those laboratory parameters. The blood film and the DAT, however, are really more specific orienting tests. You'll see schistocytes and spherocytes respectively. You've got a vowel as your mnemonic there. And the DAT, of course, is usually negative for intravascular and positive for extravascular. The biological mechanisms of intra versus extravascular are often easily inferred, but there are some exceptions. So fragmentation hemolysis, osmolar hemolysis, and the pores of the membrane attack complex and paroxysmal nocturnal hemoglobinuria are obvious examples of intravascular lysis, but there are some examples of extravascular hemolysis that may not be quite so intuitive. Extravascular is again a reticuloendothelial clearance pathway, and phagocytosis is usually involved in the spleen. That is the classic case for IgG-mediated hemolysis. Complement opsonized red cell clearance, however, doesn't entirely happen in the spleen, and splenectomy is not as successful a maneuver for complement-mediated hemolytic anemias seen in cold mechanisms, for example. Where are those complement receptors for complement opsonized cells? Unfortunately, many of them are in the liver, and you certainly can't do a therapeutic hepatectomy to fix those problems. Now, there is also eryptosis to consider. This is a unique term relegated to erythrocytes. They can't use the word apoptosis because there is no nucleus and therefore no nuclear program for cell death. Eryptosis therefore speaks to the chronobiologic signals of senescence that we're naturally endowed with, so that red cells don't exist for more than their typical 120-day lifespan. As red cells age, they become biochemically warped. They become depleted in their bioenergetics. They don't generate as much ATP. They're rigidified. The energy that's required to maintain membrane polarity is lost. You get eversions of negatively charged phospholipids, typically oriented to the inside of the cell, flipping to the outside. You have clusters rather than separations of band 3 studded across the red cell membrane as ferric or oxidized iron binds to the bottom of band 3 as a hemichrome. So we have a lot of these pattern recognition motifs for these warpings. Oxidative damage, in turn, can cause changes in the nature of different bonds and angles of macromolecules. And so again, an unfit red cell within the spleen will be detained. It may not be able to squeeze its way through fenestrations narrower than itself and ultimately get cleared. Intriguingly, the serum of people with hyperhemolysis can induce eryptotic changes in vitro with normal red cells making contact with that material. We still don't know what all of those mediators or evil humors are, but obviously that's an area of active study. Various dysmetabolic states and sepsis can also accelerate these senescence features of red cells and therefore red cell clearance. Rigidification can happen, as I mentioned, with ATP depletion, and that may be the case for long stored blood. You may not see an increment, but you may not see overt or immediate parameters of lysis with that loss of an anticipated increment. And this may speak to temporary sequestration of transfused older red cells within the spleen. Other infections, erythroparasitic infections, may cause rigidification of red cells and sequestration within the spleen. Now, the oxidative changes of G6PD deficiency are also, at the end of the day, extravascular flags. Though the blood film may look like it's been carbonated with those bites and blisters, that doesn't necessarily connote that the bulk of red cell damage and clearance is happening in the intravascular space. Oxidized, oxidatively damaged red cells have the features that the spleen will recognize for their clearance. This is an excellent review article that I recommend if we want to delve deeper into hemolysis beyond the immune mechanisms that this session is speaking to. So this will cover congenital and acquired non-immune, as well as immune mechanisms. In 2010, interestingly, a group found that red cell specific antibodies may not just opsonize red cells for their phagocytic clearance, but actually, if they land upon specific systems of relevance, like the glycophorins, stimulate a signal transduction cascade that leads to red cell lysis directly without requiring a phagocyte. So this is an example of direct lysis achieved by an antibody. So explanations for why some hemolytic anemias are more or less severe than others relate to the antibody, how much you have and how avid it is, what its subclass is. IgG4, for example, is a less hemolytic subclass. There's the amount of antigen that is the target of that antibody. What's the density? Is it single or double dose? What conformation is that antigen in? Is it set up for ideal binding? How much complement do you have and how activated are those systems? How hungry is the reticuloendothelium? What is the activity level of those Fc gamma receptors? How tilted is your cytokine axis? And are you depleted of your T regulatory cells? Finally, how much CD47 expression do you have? This is the do not eat me signal on erythrocytes. And if this is running low in expression levels, then the red cell is more subject to phagocytosis. You can see CD47 here in this navy blue band within or as a part of band 3 complex. If CD47 engages with SIRP-alpha on the monocyte or macrophage, that cell relaxes. This is the do not eat me ligation or signal pathway. This is why anti-CD47 has been developed as a therapy. This will insinuate itself here so that CD47 does not bind to SIRP-alpha. Anti-CD47 monoclonal antibodies saturate these receptors and leave SIRP-alpha non-agonized. The monocyte and macrophage, therefore, does not have the do not eat me signal and is therefore hungrier and more apt to phagocytose aberrant cells such as tumor cells. This diagram here illustrates that in addition to activating Fc receptors, we have an inhibitory Fc receptor called Fc gamma receptor 2b. 2b is not to be as activating as these other receptors on the left. It was once thought that sialylated isoforms of IVIG were preferentially stimulating those inhibitory Fc receptors, but that this hasn't been reproduced. Instead, however, there are labs working on other substances that may stimulate this inhibitory receptor to cool down a macrophage activated state. On the spectrum of DAT positivity, we appreciate that there isn't always a correlation with the presence or degree of hemolysis. If you have warm autoimmune hemolytic anemia or an obvious delayed hemolytic transfusion reaction, you may be both DAT positive and obviously have correlative hemolysis. On the other hand, you may be DAT negative and yet have quite significant hemolysis. We have examples of seronegative hyperhemolysis syndrome or examples of subserologic IgG opsonizations. So you need up to 500 IgG molecules for your DAT to be positive. But if you have 300 IgG molecules, you may end up with the negative DAT and still have quite significant hemolysis. Alternatively, maybe you don't have a serologic mechanism for increased red cell clearance. Maybe you have direct cell-mediated toxicity. Maybe you have that glycophorin binding antiprotease antibody leading to DAT negativity or destruction of every cell that had an antibody once landing upon it. The negative control lands in this last quadrant. So this is the expected result in a healthy person or in a person who has anemia due to other causes. Intriguingly, there is a final category that belongs here, and that is the phenomenon of non-hemolytic red cell antigen loss. This is the situation where you might get transfused with multiple units that are known to be antigen incompatible. For example, someone might have gotten 10 units of JK positive blood in a massive hemorrhage protocol. They had an antibody card speaking to their history with anti-JKA, but that antibody wasn't identified on the screen, or we didn't wait for the result of the screen for the emergency transfusion scenario. By the time that antibody gets recognized, all of this incompatible blood is inside of the patient. And yet, when we sample them afterwards, we don't see the JK antigen on the phenotyped red cells in vivo, and we don't see a positive DAT either. How does this happen? Well, it appears to be a non-erythrodestructive antigen tearaway. It doesn't appear to need a spleen, but Jim Zimmering has found, in mouse models at least, that this isn't something that can happen in a test tube. It probably requires a liver with Fc gamma receptor 3, and it probably needs simultaneous cross-linked antibodies with separate specificities for parts of the same target antigen. The relevance of this phenomenon is not only to explain these bizarre scenarios of averted hemolytic transfusion reaction harms, but also potentially to explain allograft accommodation and maybe even therapeutic monoclonal antibody resistance. For example, the lymphoma that seems to have adapted to anti-CD20 therapy faster than clonal evolution within a tumor could possibly explain. So let's jump into 5 different cases. In case 1, till the cows come home, we're going to be asking questions like what condition obfuscates everything, and what is the conflict between the blood bank and the bedside? So just as Eskimos have many words for snow, the blood bank has many names for the specimen that we receive that is the basis of compatibility testing assurance. The sample goes by names like the blood group, the group and screen, the type and cross, the cross and type, or the cross-match sample. At the end of the day, we're getting all the evidence we need from the red cells and the plasma that are centrifuged and separated for further analysis. Who are the potentially screen positive people? The people whose yellow stuff reveals anti-red cell antibody specificities. These are people who've seen a foreign erythrocyte, who've processed foreign alloantigens, and who have decided, rather than to be tolerant to them, to instead develop antibodies against those targets. This is anyone who's been pregnant. This is because there's a little bit of fetal-maternal hemorrhage occurring at parturition and at any other traumatic or invasive sampling points in the gestation. This can be any transfusion history, obviously, and even exposure to any tissue grafts or transplants that might be contaminated with passenger erythrocytes. So in this case, we have an octogenarian gentleman who presents after a fortnight with fatigue, exertional dyspnea, dizziness, and dark urine. Never been registered here before, and he takes no medications, and he has no scars on exam. And these are his parameters. So he's profoundly anemic with indirect hyperbilirubinemia, a high LD, reticulocytosis, spherocytes, and a pan-reactive screen on his group and screen. The reflex DAT also showing strong IgG reactivity, 4+ on that 4+ semi-quantitative scale, with 1+ reactivity for complement that appears to be getting fixed here. We make an eluate of whatever was binding to his red cells, and it appears pan-reactive. The blood bank is saying it's going to take hours to resolve tests of compatibility and to assure the safest possible red cell release. And herein is the conflict, because of course the blood bank does not want to release anything before its testing is done, while at the bedside, There's a desperation to get blood into the patient as soon as possible. And so this is a tension that needs to be carefully negotiated. And if it's appropriate to skip tests or to commit to an action and review the results later, then this is where the art and science of clinical decision making or risk based decision making has to come in. So here are the spherocytes on his blood film. And yes, he has indiscriminately positive blood bank reactions. He has what's known as a panreactive plasma. The DAT is positive, and when we create a solution, when we strip off the antibodies that are bound to that red cell surface, that's called an eluate, and we treat it the way we did the plasma in reacting it against informative reagent red cells, we find that same indiscriminate panagglutinating look. And so these are like misanthropes. You can't love others unless you love yourself, but if you're a self-hater, you will hate everything else with equal rigor. So this autoantibody is obfuscating our vision. We can't see if there are alloantibodies lying beneath. Now, this gentleman's clinical story would predict that there aren't going to be any of these. But if we didn't have such a reassuring pretest probability, we'd really want to spend the time to look for the existence of these alloantibodies because these are going to be obligate points of matching. If you have an alloantibody, you certainly don't want to transfuse the patient with an alloincompatible unit because that will be an attractive target in its entirety for the alloantibody the patient possesses. The autoantibody, on the other hand, is distributed equally between the transfused unit and the rest of that patient's current and emerging red cell biomass. So getting back to this isolated and messy plasma, we want to clean this up, and that means absorbing or adsorbing out the blinding material. If the patient has not been transfused, we can use their own erythrocytes as the adsorbing material. Now, this red cell biomass may currently be saturated in its binding with autoantibodies, but you can clean that red cell surface up by using ZZAP, and this frees up more binding sites by which to attract out autoantibodies when you reunite those cleaned red cells with that patient's plasma specimen. So going through one or more cycles of this, you can pull out more and more of these autoantibodies and eventually be left with this clarified, diagnostically informative material. This plasma here will reveal to you the existence of the alloantibody with its own specific pattern of reactivity. If you have nothing beneath, you'll have a clean, finally negative screen. So if you appreciate how long this maneuver takes, you can make a decision to transfuse in the meantime, or if it's really important to get this result and the patient is stable, to then wait for the result instead. If this testing isn't done, you do have to sign these variance forms to indicate that you've requested blood before the work of the blood bank is finished. But that's a clinical decision, and if it's one that makes you nervous, we're happy to have your back and to cross-consult to help make that best possible decision. How low is low? Many other jurisdictions that aren't as blessed with resources wait to trigger at much lower hemoglobins. 40 and below defines profound anemia, and 50 or below defines severe anemia. So again, depending on the resources, you may be triggering up here or lower down. The survival limit for anemia is at 15. It's courtesy of Jehovah's Witnesses that we've been able to build these survival curves. So at a hemoglobin of 40, the probability of survival is about 60%, or conversely, a death rate of 40%. So this patient transfers to the floor while hematology is following him. And a decision was made to await the completion of all the tests because nobody wanted to gamble and he appeared to be tolerating his anemia. The problem is it takes 2 points to make a line and 3 points to determine a nonlinear slope, an accelerated destruction situation, for example. And unfortunately, nothing got specified beyond the default of next morning blood work and routine vital signs. So while that was set up, he went to the floor without telemetry. We did the adsorption, we did the phenotyping, we sourced antigen negative units that looked just like him. And though those cross matches with antigen negative units were nevertheless incompatible as expected for a warm auto, the adsorbed plasma performed very well. So we called the floor and we said, hey, the blood is ready. But then the floor said, don't bother sending anything. We've just concluded the code blue. We found him cold and dead in bed. So the risk of harm, doing something incomplete can indeed often be less harmful than deferring to the perfection point. Okay? Look at your patient. What are the odds that he can tolerate his anemia? What is the risk of not transfusing? And what is the likelihood of him having antibodies or the risk of transfusing on cross-matched blood? Okay. In him, that was low, but the likelihood of an adverse event from anemia was high. So this was a scenario where calling the transfusion physician on call would have been helpful. We've altered our policy as a result of this case. And indeed, if someone is taking too long to make a decision to transfuse someone with profound anemia, someone presenting with a serologic abnormality that is taking hours of work to resolve, we do get the transfusion physician on call to position themselves into the conversation so that we make the best possible decision for the patient. We can always act now and figure out or intercept later. So if the unit is half transfused by the time we recognize that it's not the best possible unit out of better ones that are in the blood bank for trade out, we can always flip, but you can't do that if the patient is in a protracted position of deprivation. Indeed, compatible blood is useless to a corpse. Now, if he had survived, we'd be asking about whether or not there are underlying autoimmune conditions that are part and parcel of his hemolytic anemia presentation. So think about other causes. Is he one checkbox away from fulfilling criteria for lupus? Does he have a driving immunodeficiency state such as HIV infection or combined variable immunodeficiency or IgA deficiency? Does he have a lymphoproliferative disease? Might his blood film show the smudge cells of CLL as the aberrant antigen presenting cell that is the classic driver of various immune cytopenias? Are there other non-lymphoid malignancies where this is a paraneoplastic presentation? Or are these cancers undergoing treatment with checkpoint inhibitors that have unleashed this and or other kinds of autoimmunity? Is there an infection or a vaccination that has induced an anti-pathogen antibody that by molecular mimicry cross-reacts with the host red cells? So again, there are a number of congenital states that are prone to antibody-mediated cytopenias that may also concomitantly suffer other kinds of immune dysregulation. Mimics of immune hemolysis can include those obfuscating pan-reactors, the therapeutic anti-CD38s, which thankfully probably decrease the risk of allo and autoantibodies forming hence and may even treat them in retrospect, versus anti-CD47, which ramps up phagocytic activity. So this one is a little more problematic. But immune checkpoint inhibitors are quite challenging because these are unleashing true autoimmune hemolytic anemias, if this is what we're seeing serologically on the DAT and on the IAT. So these new drugs taken together are producing a lot more work for us in the blood bank by confusing us or directly inducing real new pathologies. This is a classic picture of the immune synapse showing how many inhibitory or tolerance-inducing ligands there are. And when we try to break that tolerance with CTLA-4 or PD-1 blockers, we are unleashing more T cell activity in response to an antigen-presenting cell's antigen of interest to the T cell receptor. Can transfusions induce immune hemolysis? Perhaps, and certainly in the case of hyperhemolysis syndrome, there would be no other explanation. But many other times, an autoantibody may develop, and we may speculate that a foregoing transfusion had something to do with it. This very interesting paper by Jim Zimring speaks by non-exofacial polymorphisms to a model that may help to explain both the capacity to reactivate historic antibodies despite giving antigen-matched blood, as well as to possibly explaining the production of autoantibodies, particularly in the scenario of giving supermatched material. In other words, this is to say that non-exofacial polymorphisms linked to an antigen presentation may drive immunogenicity even though antibodies don't land on the non-exofacial side of a cell. This very nice visual abstract from a blood review paper on immune hemolysis covers standard therapies for warm autoimmune hemolytic anemia, as well as a number of off-label options or considerations that run the range of EPO to danazol to complement inhibitors to anti-lymphoma cannons to splenic tyrosine kinase inhibitors, anti-FcRn drugs, as well as rheumatologic or anti-rejection medications. Do not be confused by the anti-worm antibody. We had an incident where a clinician thought that an anti-worm was an anti-worm high prevalence antigen. Yes, patients with warm autoantibodies can be hard to get perfectly matched blood for because we're trying to find a profile that emulates them. But that's not the same thing as a high prevalence antibody with a specificity that is hard to bypass in terms of rare donor stocks. So there is no such thing as a worm antigen. This was a phonetically misconstrued diagnosis. Let's flip to case 2 now. Passive aggressive. What's the difference between active versus passive hemolysis? And can you hemolyze to death from yellow stuff? So in this case, we had a 52-year-old presenting with probable ITP about 10 years after an allo-BMT for underlying ALL. She came in with a platelet count of 0, epistaxis, and got a very high dose of IVIG that was not weight adjusted, so 100 grams on a Thursday and a Friday. And because they were querying the return of ALL and she was having a bone marrow done, they didn't want any steroid confounding effects on the hematopathology. On the eve of the second dose, she returned to the emergency room in atrial fibrillation with angina and dyspnea and severe anemia and cola-colored urine. So this is the cartoon for passive hemolysis. It's a minor incompatibility scenario. And what we had here was IVIG containing hemolytic anti-A or anti-B. This patient was born group O but transplanted to group A. So the graft-encoded red cells that she was circulating with were type A, and she didn't have any A antigens expressed on other tissues to distract the anti-A hemolysin that was present in the IVIG. So this anti-A from the IVIG landed specifically and only on the erythroid biomass of this engrafted donor. This is the ABO pie graph for the population showing the isoagglutinins that are peculiar to every single blood type except for group AB, which only comprise 4% of our donor supply. So this means the 96% of those 50,000 plasma bags that constituted a specific lot of IVIG contributed either anti-A or anti-B or both. And so the through line, the common denominator antibody to IVIG are the antibodies of Landsteiner's law, the expected antithetical isoagglutinins building up in the product. It is only a specific brand that might have a manufacturing process to pull out or absorb out anti-A or anti-B so that you have a hemolysis reduced risk product to administer to a patient. Her case was a nice example of passive immune globulin mediated hemolysis. Yes, we see this in IV anti-D IgG given at high dose to people with ITP who are RHD positive, the 50 to 75 microgram dose per kilogram. That's got a black box warning associated with it. And while it is typical to see a 10 to 20 point drop in hemoglobin after such an infusion, the scenario of severe hemolysis, so bad that you co-present with ATN and DIC, might happen 3 in 10,000 times. IVIG associated hemolysis is usually not this severe, but it does happen. And this is peculiar to people getting high dose treatment who are themselves not blood group O. So it's the A's and B's and ABs who are susceptible to this. 60% of people getting high dose IVIG who are not group O will become DAT positive for the relevant isoagglutinin that their red cells are attracting. And a third will hemolyze to some extent, with a third of that third doing so severely. And so we typically, at informed consent for high-dose IVIG to non-O recipients, mention the fact that there's this 1 to 10% risk of significant red cell loss. And if that happens, we will bypass the ongoing hemolytic effect of residual isoagglutinin by giving group O instead of type-specific transfusion support. Now, passenger lymphocyte syndromes are the active example of this scenario. You might be getting a graft that comes from a person who is screen positive for an antibody that is relevant to the host's red cell type. For example, a D positive recipient of an allograft from a D negative donor who is already anti-D sensitized. The power to secrete anti-D is going to be stimulated and selected for on entry in a recipient body that is coursing with RHD positive erythrocytes. This is a minor incompatibility scenario of donor origin, of graft-associated alloimmune hemolytic anemia of host red cells, a humoral graft versus host disease for the blood bank to pick up. Let's go to case 3, search satisficing. Does every positive DAT mean a warm autoimmune hemolytic anemia? And what is an eluate? Here we had an 18-year-old with brittle type 1 diabetes who presented with pedal osteoinfection. And 5 days into his treatment with Piptazo, he experienced a loss of consciousness with profound anemia, requiring transfer to the ICU. His DAT was positive, and he had spherocytes on his blood film. So the consults team started high-dose steroids. With that, though, the hyperglycemia got worse, and the hemolysis did not improve. Someone didn't notice the result of the eluate. So yes, he had spherocytes, and he was DAT positive. So you can see how someone might be search satisficing or misconcluding that this is enough evidence for an immune hemolytic anemia that is a warm auto requiring steroids. What they did not take heed of was the fact that the eluate was importantly non-reactive or negative. Again, the eluate is that material that is lifted off of the red cell surface. This is a solution of the antibodies that were binding to your patient's red cells. This material, when reacting with reagent red cells, had no interest or cognate relationship. This is not what you would see in a warm auto. This is revealing the fact that this is a drug-dependent antibody. None of these reagent red cells are coming from a person stewing in the same drug that this patient is taking. If we were to co-incubate these red cells with piptazo, well, then an anti-piptazo-dependent antibody might then reveal and react with that red cell. But again, if none of your red cells on your panel here are reacting with your eluate, do think that this is a drug-induced immune hemolysis instead. So there are many conformations by which an anti-drug antibody may bind. The antibody may bind to the drug, and the red cell may flow against that complex and absorb it, and that's how the red cell gets taken down. Or the drug is binding in a hapten-like fashion to the red cell, where the antibody is binding to the drug or a portion of the drug and a portion of the red cell at the same time. So a codependent or dual antigen, neoantigen situation. It's not important what the cartoon conformation or technical revelations are here, but that you recognize that if you have a new hemolysis occurring after the initiation of a drug, and that the eluate is negative, that this is an important clue that you have drug-induced immune hemolysis. So this is a list of commonly implicated medications, and you can see that piptazo is on this list. This is not to be confused with G6PD deficiency-related oxidative hemolysis. Again, as an X-linked trait, this is going to be predominantly seen in genetic males, and this is going to have a completely different blood film with a negative DAT. So if you have this particular list of medications, these blood film findings and a negative DAT, well, then you're thinking of drug-induced oxidative rather than drug-induced immune hemolytic anemia. Now for case 4. Blood did or didn't run cold. How many kinds of cold hemolysis are there? Here we have a 64-year-old gentleman who is suffering ulcerations and skin necrosis of his rhinophymus nose. He had bad rosacea. And this was happening after working outside in mining operations. He's increasingly fatigued, pale, and he's noticed pain in his gullet when he imbibes ice-cold drinks, cold odynophagia. His blood specimens at the family doctor's office are deemed unreadable because of clumping. So this brings up antibody isotypes, IgMs, pentamerize. And if you take heat out of a system, molecules that like to organize will do that even more so. IgMs by pentamerization stay a lot more intravascularly confined. And if you have an IgM that is red cell specific, well, then those red cells are going to be brought together in an agglutinate. So this is the classic mediator of cold agglutinin disease. IgG, in contrast, is an isotype descendant of IgM typically raised against protein targets. And this stuff gets distributed as extravascularly. So as much as intravascular as extravascular. This is somewhat less complement fixing or complement binding as IgM. And this, as a warm active antibody, is the signature isotype of the contrast that is warm autoimmune hemolytic anemia, already spoken to. Now the DAT. The DAT is a polyspecific blend looking for IgG or complement. And if its result is negative, you stop there. It's either a true negative or a false negative. Conversely, if your polyspecific Coombs is positive, we then pull out our monospecific reagents to resolve whether this was due to IgG or complement or both. If it's only IgG on the red cell surface, then that is typical for a warm active hemolysis, such as autoimmune hemolytic anemia or an IgG-based DHTR. On the other hand, if all you've opsonized is complement, C for complement, C for cold. Complement is the classic recruited or fixed opsonin in cold mechanisms of hemolysis. There may be overlaps, and that could be a mixed warm-cold or a warm autoimmune hemolysis that has the capacity to fix complement. So these are your differential diagnoses based on what your Coombs test readout is at this level of detail. The differential diagnosis for complement opsonization, again, is shown here. There are two kinds of cold immune hemolysis: paroxysmal cold hemoglobinuria or cold agglutinin syndrome, cold agglutinin disease. Paroxysmal nocturnal hemoglobinuria may show up here as well, especially if someone is on a C5 monoclonal antibody, because the membrane attack complex is not being formed, and you have a buildup of the upstream modes of complement deposition. So again, the two kinds of cold autoimmune hemolytic anemia, typically complement positive and IgG negative. Cold agglutinin syndrome is the majority of cold immune hemolytic anemias. It's IgM mediated, hence you witness agglutination. This sample needs to be submitted warm in an EDTA, and we control the cooling and therefore the determination of titer, the number of dilutions it takes to disrupt the agglutinates seen at different temperatures, or the so-called thermal amplitude. Paroxysmal cold hemoglobinuria, on the other hand, is an IgG-based hemolysis, and so you won't see the signature agglutinates because IgG stays monomeric. And so you have to infer its existence by the fact that it induces a biphasic hemolysin activity. That is to say, there is a phase of IgG binding, which then leads to complement fixation. And on warming to in vivo core body temperature, you enter the range of complement activation. Complement-mediated red cell lysis takes over. The test done to establish the existence of this phenomenon is the Donath-Landsteiner test, and that's a red top tube specimen, also submitted under warm conditions so that we can set up our systems with total control. One system, after being obtained warm, stays warm. Another system is allowed to cool and stays there. And a third system cycles through both cooling and then rewarming. We use the patient's serum, a new source of antigen-positive red cells that a Donath-Landsteiner antibody is expected to bind to, and a fresh source of complement. And what we see across these three systems is hemolysis only occurring in that thermal arm that went through both cold and then warm conditions. PCH can also have erythrophagocytosis seen on the blood film. The target of cold agglutinins is classically the precursor antigen in the ABO system, the I or the H molecule, and in contrast in PCH, the target is the P or globoside antigen. So the pathophysiology of cold agglutinin or paroxysmal cold hemolysin antibodies is as follows. At peripherally cooler temperatures, the operating antibody binds, and at centrally warmer temperatures, the complement activation takes over from the complement fixation that occurs through the antibody. If you have an IgM, you're going to witness agglutination as well in that cold binding phase. If you have PCH with an IgG, though, you won't see the agglutinative correlate clinically or in vitro. So the management of cold immune hemolysis is to get the patient warm and to avoid occupations that expose the patient to discretionary cold situations. Classically speaking, various immunosuppressives were good at restraining the lymphoplasmacytic output of the IgM or IgG that was causing the cold agglutination or PCH respectively. So that could be cyclophosphamide, chlorambucil, or alpha interferon. But what's more popular now than any of these cytotoxic agents, these alkylators can cause dysplastic harm downstream, is to just use chemoimmunotherapy, use rituximab and anti-CD20 therapy off-label to kill off the cells that are generating this problem at the root cause level. Apheresis is handy at skimming off IgM because, again, its intravascular confinement makes it very accessible for a good kinetic removal. This visual abstract from another blood review paper on cold agglutinin disease shows again the central position of rituximab today, with or without bendamustine. And you can see that second line are a number of complement inhibitors or other myeloma cannon borrowed therapies. The complement inhibitors to be considered off-label or on-label, depending on what the case may be, would be eculizumab or sutimlimab for C5 versus C1 blockade. This, however, doesn't get rid of the root cause. It just helps you cope with the latter phase of the pathophysiology, the impact that complement fixation and complement-mediated lysis will have on the red cell. This is the last case here, case 5 on overreaction. So why is there so much transfusion policing in sickle cell disease? What are the specialized red cell transfusion requirements? And what is the deadliest kind of immune hemolysis? So this 38-year-old male with sickle cell from Southwest India presented with a vaso-occlusive crisis. He was transfused 2 units of red cells. Because he'd been in Canada for about 20 years, he'd only had 3 groups and screens on file. They were done before a transfusion, but he was never rescreened in that 1 to 3 month period where he might have most likely evidenced any seroconversions if they had occurred. He therefore looked consistently screen negative, so therefore only got prophylactically antigen matched blood, CE Cal matched. What happened? 2 weeks later, he presented with a DSTR. Even though he had gotten big E negative blood in accordance with the policy, he flashed back or reactivated his historic anti-Big E, which we again didn't know about, as well as 2 other minor alloantibodies that he certainly was not matched for, anti-Duffy A and anti-little s. We retrieved the segments from the units that he had been transfused with, and unfortunately, they were positive for Duffy A and little s. So he had within him now antigen-incompatible blood in accordance with his current antibody repertoire. Unfortunately, within 2 days of this presentation, he died of hyperhemolysis syndrome. So transfusing sickle cell disease takes into account quantitative and qualitative aspects of decision making. On the quantitative end, we're constantly wondering whether or not a top up can get you into a situation of greater harm than benefit. If you are simply stacking on more hematocrit, normal hematocrit, on top of non-deformable, unexchanged red cell mass, you may increase whole blood viscosity and actually hijack vascular perfusion, no matter what the oxygen affinity situation may be. And so you may actually be decreasing tissue oxygen delivery, paradoxically. And so we're mindful of what's known as the sickle crit. If you get above a threshold of 20%, the cross product of the hematocrit by the hemoglobin S percentage, we back away from top-ups and instead consider partial manual red cell exchanges or automated erythrocyte apheresis, depending on how important it is to do a deep exchange for the current clinical situation. Obviously, if it's an acute chest syndrome or a stroke, we want a deeper exchange rather than a more superficial exchange. Qualitatively, the decision here is the depth of matching. And so prophylactic antigen matching is the established norm for the consistently seronegative patient with sickle cell. But if you have a patient who has any history of antibodies, they need a high fidelity supermatch and extended antigen match instead. Hyperhemolysis is an exaggerated form of a DHTR with bystander red cell takedown. The patient's post-transfusion hemoglobin is less than what the trigger was, so this is a negative increment. The majority of cases occur in people with sickle cell, though this has also been described in thalassemias, in MDS, and in lymphoproliferative diseases. We quote a risk when we give informed consent to patients with sickle cell of between a 1 in 100 to a 1 in 1,000 chance per transfusion sitting. This has a high case fatality rate, between 5 to 25%. And unfortunately, a high recurrence rate too. So if you have a survivor who ever reconfronts blood despite supermatching, half of these patients have this happen again. This is a hemovigilance reportable event. This is distinctly transfusion triggered, whether or not the event appears to be seropositive or seronegative in its effects. The mainstay of treatment is high-dose steroids pulsed with high immunomodulatory dose, IVIG. So the steroid doses are akin to those in acute demyelinating encephalomyelitis, and the dose of IVIG is high and therefore concerning in the capacity to also passively introduce and exacerbate hemolysis in the short term before longer term reticuloendothelial cool down. And so this means that if you're giving high-dose IVIG to a non-O recipient, that you may consider stretching that treatment out over 5 days instead of over 2 days. This blood paper speaks to core principles of management. So in addition to high-dose steroids and IVIG, to consider giving EPO for the reticulocytopenia that is also a classic feature of hyperhemolysis syndrome, rather paradoxically, so you don't have the compensatory reticulocytosis that is expected for hemolytic anemias. You want to have thromboprophylaxis on board because such a degree of hemolysis is indeed quite prothrombotic, and you want standard supportive care. So eculizumab is an important agent to introduce as soon as there's evidence of acute chest syndrome, pulmonary hypertension, stroke, or other organ failures. It's believed that complement-mediated pathologies are contributing to this picture, and therefore we want to arrest that cascade. Now, I've added here rituximab, even though it doesn't act quickly, and even though it doesn't take away the antibody that may be currently a feature of a seropositive conversion case. It may at least prevent downstream additional seroconversions, or it may be the mitigating medication given to a patient before the next transfusion exposure, be it the one that's part and parcel of the management of this presentation, or if it's the post-recovery patient who downstream in the future might need a transfusion. So again, think about anti-complement and anti-B cell actions in this syndrome. Now there's a scoring system here for the odds of this happening, or who ought to be stratified to better seroconversion prevention, that is extended antigen matching. And so we're generally speaking adopters of this score, though we tend to make a more binary decision between prophylactic antigen matching for reassuring score people. Those are people who've been many multiple times transfused without any seroconversions, so consistently seronegative or blood tolerant people on this end, versus those who get extended antigen match if we're unaware of their history or if they haven't been transfused enough for us to be confident quite yet. So any history of a DHTR or a lack of confidence by these other means should land you in a more high fidelity matching scenario. Should you ever do plex for these patients? Well, because there's a physiologic anemia exacerbation when adapted to the apheresis circuit due to the amount of blood that's being processed ex vivo, you generally need to be transfused up to a hemoglobin of 70 or 80. And that's a deadlock situation here because transfusions by themselves exacerbate hyperhemolysis. So they are relatively, if not absolutely, contraindicated at this time. So what this means is that generally speaking, the answer to this question is no. And so the real role for apheresis in hemolytic anemia patients is generally more for those cases where it's known to have an impact, where it's easy to scoop out a pentamerizing intravascularly confined IgM, or where you can make a dent in a high titer antibody that is playing a role in someone's pathophysiology. You might also justify this as a form of detox, so to clear away those red cell breakdown products that may be elaborating at a high pitch and causing downstream harms. So at certain levels of high free plasma hemoglobin, you may have ATN and you may want to avert or mitigate that outcome. There may be stromal factors and drivers of DIC. On a final note, I want to acknowledge polyagglutinability, so states of crypt antigen vulnerability to pre-existing antibodies that are present in our plasma. Our antigens get processed with a number of post-translational modifications, and these in essence act as shields. This is how we construe our version of normal. However, there are certain states, such as bacterial sepsis elaborating exotoxins, that may strip off some of these side chains or post-translational modifications, and in so doing, reveal crypt antigens that we have naturally occurring antibodies against. And so the classic example of this is acquired B, which we spoke to in the ABO session. GalNAc, N-acetylgalactosamine, has its N-acetyl group clipped off by the deacetylase elaborated by Clostridial infection. That converts GalNAc into galactosamine, which looks enough like galactose to interact with anti-B or galactose-specific isoagglutinins inherent to a group A person's plasma. By analogy, these various kinds of polyagglutination that can be detected with these different kinds of lectins may reveal a target to which someone has a current antibody repertoire. We don't normally reveal these cryptantigens, but they may be revealed by pathologic stripping processes, or on the other hand, by abnormal dyserythropoietic or faulty production pathways that simply leave antigens in their cryptantigen state. Now, if you have a profoundly anemic patient, there are other tactics up your sleeve, again, in the thought line of supportive care. So here, you want to reduce cellular oxygen utilization or demand, and you can do that by cooling the patient or resting the patient. And in extreme forms, that would mean having the patient put to sleep or through neuromuscular blockade paralysis. So using the help of anesthesia here. Conversely, you can increase the oxygen supply. And even though plasma is not an efficient carrier of oxygen, by providing an FiO2 of 100%, you can dissolve enough oxygen in the plasma to have the effect of 3.5 units red cells worth in terms of cardiac relaxation effects. So you can make a hemoglobin of 56 behave more like a hemoglobin of 89. And you can go above an FiO2 of 100% with the hyperbaric oxygen chamber. And as this case of a Jehovah's Witness illustrates, this lady who suffered a massive postpartum hemorrhage and a hemoglobin of 19 survived in the period that it took for her to build up to a day 35 hemoglobin of 63 by getting into the hyperbaric oxygen chamber 90 minutes twice a day at 2 atmospheres until she was tapering down to every other day 30 times over that 29-day treatment period. So this is one way to superoxygenate a patient, to have other parts of the bloodstream carrying oxygen if there isn't enough hemoglobin to do that work. And that concludes our 5 cases. So I thank you for listening.